idea of this workshop is basically to talk about how we run a heart failure clinic. There are a number of centers in India now which have started running heart failure clinics, and the numbers are gradually increasing. We also have trained heart failure nurses, which are basically nurses which we have pulled in from cardiology and cardiac surgery, and then we have trained them in various aspects of heart failure, so they can act as a, in a way, force multiplier for all of us. And if I can just get an idea of where all the doctors who are participating are from. I've seen the Excel sheet, so they seem to be from just about everywhere, Jaipur, Punjab, everywhere. So if some of you, while we have 5 minutes, can introduce yourself and tell me what kind of clinics and OPDs and hospitals are you from, so that'll help me modulate my talk.
Good evening. I am Dr. A.K. Pandey from Varanasi.
Okay.
Actually, sir, we have got a multi-specialty hospital where I practice. It's a private tertiary care hospital. We do have a non-invasive and invasive cardiology setup at our center, but we don't have specialized clinics like heart failure clinics, arrhythmia clinics, and so on. We keep on seeing the three of cardiologists. We practice as a group practice in our hospital, and we have got three other junior cardiologists with us. But we don't have such a programmed or structured heart failure clinic. So definitely we are thinking of to start a 1 day in a week to make a heart failure clinic day to make the better care for such patients, because now we get a mixture of patients. Like most of our patients are, though they are having CAD, some of them are having normal LV function, some of them they have reduced EF or have PEF, but they are coming in a mixture of rheumatic heart disease and valvular heart disease and so on. So we don't have any structured program, because many times the centers like us, those are small centers, we don't have too much of referral patients. So we can't make it a specific day, but we are trying to improve the heart failure patients care by making some structured program, giving them when they get admitted, at least give them some advice with the help of a cardiac nurse to how to maintain their lifestyle, what are the fluid and salt restrictions, and regarding their dietary habits and medications and so on.
So do you
So
have a
these are,
OPD every day?
yeah, sir, we have a OPD every day.
So what are the hours for the OPD?
Usually, sir, we have got three of us with sits at a different time interval. One of my colleagues sits in the morning hours from 10 to 12, other from 12 to 4, and other the I sit usually from 2 to 7. So we have got a separate times for each of us.
So that'll be 6 days a week or 7 days a week?
We have got 6 days in a week.
Okay. So this is what I wanted to know from some more of you, that what kind of OPD services, what kind of hospital services you have. Because then it'll be easy for all of us to discuss how we can, without causing major changes in a hospital structure, start a heart failure service. And on the
Right.
similar pattern, then you can set up a arrhythmia service, a coronary service. The idea is to work with what you have rather than trying to set up things which are not possible.
Yeah,
Anyone else would like to talk about what kind of clinic and hospital and services they have?
So, good evening, doctors. I am Afreen Naik from the medical team of JP Pharma, and I welcome you all to this super interesting session this evening. Heart failure is likely to be an important contributor to death and disability in developing countries because of increasing vascular disease as well as the persistence of pre-transitional diseases such as rheumatic heart disease and infectious cardiomyopathies. The Indus study, of which Dr. Sandeep Seth, who is our esteemed speaker for this evening, was part of, suggested that an alarming burden of heart failure in India, despite a younger population, is there in India despite a younger population than the developed nations. A significant proportion of this burden may be preventable with better screening and early, adequate, and focused treatment of the risk factors. An article mentioned that India is home to nearly 40% of the world's heart failure patients, a major chunk of which is attributable not only to lack of awareness but also suboptimal treatment. An article in the European Heart Journal mentions that generally 25 to 50% of hospitalized heart failure patients will be readmitted within 6 months after discharge. The most frequent causes of worsening heart failure symptoms and readmission are poor compliance with fluid restriction, or insufficient medical therapy. From various documented literature, specialized heart failure clinics have shown to not only improve the quality of life and care of patients, but also reduce readmission frequencies. And today, it is my absolute honor to introduce a subject matter expert, Dr. Sandeep Seth, who's a cardiologist of national and international repute, who shall be guiding all of us taking up our queries on the establishment of a heart failure clinic, especially in the Indian subcontinent. It is my honor to introduce Dr. Sandeep Seth, who is professor in charge the heart failure and transplant services at the AIMS Delhi. He especially has research interests in heart failure, stem cells, heart failure imaging, yoga and exercise, and rehabilitation and heart failure clinics and nursing and transplantations with more than 200 publications to his name. He is also editor-in-chief of the Journal of Practice of Cardiovascular Sciences. With this brief introduction and context setting, I will hand over to our esteemed speaker for today, Dr. Sandeep Seth, to take us through his views and perspectives, after which we should have an interesting Q&A session. Thank you so much.
The concept of heart failure clinics is that you can give a bit more focused care for patients with heart failure. Now, heart failure patients are different from patients with rheumatic heart disease or coronary artery disease, for the simple reason that if you have a patient with coronary artery disease, if he comes with angina, you do an angiogram, you find a blockage, you treat it, or the surgeon treats it, and the patient is well, he goes back, he'll come back after 6 months, 1 year, and you can follow it up that way. Same with rheumatic heart disease, you find a cause which is treatable. Unlike that, heart failure varies. It can sometimes be very treatable if you can find a cause and treat the cause, but quite often you end up with patients who are just not easy to treat, and they'll keep coming back to you daily, weekly, monthly, and you are at your wit's end to understand how will you treat these patients. And especially if you're running a busy clinic, we're seeing 20, 30, 40, 50, 100 patients in one OPD, then it becomes very difficult to focus specifically on one disease. And that's what I'm going to talk about, how you can actually create a heart failure service, and then we'll interact with maybe some of you and discuss how within your existing infrastructure, without asking for anything extra, you can gently create a heart failure service. It doesn't require extra space, doesn't require extra room, doesn't require anything extra except that you want to do it. So with that, let's just get started. Now, the question which we are always asked is, why do we really need a heart failure clinic? Even in hospitals where there are heart failure clinics, there are cardiologists who are treating heart failure. Now, we all feel that we can treat heart failure perfectly. We all know the guidelines, so I'm not going to talk about the guidelines. So why do you really want to waste time and resources on creating a separate structure called the heart failure clinic? Well, treatment, as we know, has really advanced from a time when we had no treatment. It was just that you felt that you could bleed the patient, put blood-sucking leeches on a patient. So that was a time when there was actually no treatment. Most patients died. Today, heart failure management is actually quite complex if you really want to treat a patient. Starting from history taking, looking at each and every evaluation which is now available, ECGs, chest X-rays which were always available, various blood tests including BNP, troponins, iron profile, thyroid profile, you name it, you got lots of tests available, and they're pretty affordable too. Investigations are gradually getting more and more complex. Echo is no longer so simple. You have strain imaging, coronary angiograms, MRIs need to be done in some of these patients because sometimes you find a reversible cause, sometimes you find that your diagnosis was wrong. So you need someone who can help you interpret these MRIs. Nuclear imaging, sometimes if you feel that there's myocarditis, you need to be able to do an endomyocardial biopsy. And if there's familial cardiomyopathy, you need someone who can sit with you and create a family tree, because that's not only useful for that patient, but you can also prevent disease or control the disease in that family. So it's really quite complex. Treatment also has been advancing. There was a time when the treatment was limited to bed rest, fluid restriction, digitalis, diuretics. Then came the concept of vasodilators, and for quite some time that was the treatment that we had. We had ACE inhibitors, we had beta blockers, and for many years we were quite satisfied that we were treating heart failure to the best we could. So after lacunae, suddenly we started getting newer forms of therapy. Transplant in the meantime had established itself. Pacemakers had come in, CRTs, ICTs, LVADs had also come in. LVADs were getting better and better. Then the newer drugs also came in. Again, we're starting to get a whole lot of new drugs. Arni came in, Ivabradin came in. We had attempts at cell therapy with stem cell therapy for valvular heart disease for patients who had heart failure but could not go for surgery. You have things now like mitral clips, percutaneous valves, intra-atrial shunts. Newer drugs are coming out almost every year now. Starting with Arni, which gave an additional 20% benefit of mortality over the standard therapy. Ivabradin, which reduced hospitalization. Dapagliflozin, which has been, it's basically a drug which has been repurposed for heart failure. Quite useful, easy to use, not very costly, and doesn't affect the blood pressure too much also. And now Vericiguat is also available in India. And 2 or 3 other drugs are going to soon come in the picture in the next 2-3. So there are lots and lots of drugs, and it's not always easy to keep updated with each patient's therapy. Heart failure can actually sometimes be reversed. So if you have myocarditis or you have valvular heart disease or you have coronary disease, heart failure can actually be reversed. So you really need to be attentive to trying to find a reversible cause for heart failure. And if you can't treat heart failure, you'll have about 5% of patients who will be eligible for an assist device or a heart transplant. But it's not so simple. You have all the knowledge, but how do you implement all these things? And when you start implementing this, you find that you might have prescribed all the drugs correctly, or maybe someone has not actually prescribed the drugs correctly. But ultimately, if you see the patients after a few months, you find that only about 50% of your patients are actually on the therapy which is recommended, or perhaps even on the therapy which you have prescribed. Could be for various reasons. It could be that the patient cannot afford the drug, was intolerant to the drug, had some problem, didn't come back to you, could not find the drug for some of the newer drugs. Lots of things can happen. During the COVID times, there was a lot of lack of availability of many drugs. So we had to help the patients by guiding them to the nearest place where they could get the drugs. Some of these newer therapies or things like assist devices and transplant are pretty costly forms of therapy. LV assist device will cost at AIMS will cost 80 lakhs, in the private sector will cost above 1 lakh, and a transplant which for us, could we have the mic off for Dr. Jagdish, please? So heart transplant which at AIMS for a 2-year therapy, including the surgery, costs about 15 lakhs. In the private sector will cost anything from 20 to 25 lakhs just for the surgery. And now how do we help these patients? These patients can be assisted by the government. The government is coming up with schemes to help these patients, but someone has to get these patients to these assisting schemes. So there has to be someone beyond just a doctor. So what is the solution? One of the solutions that I did have a team. It can't be just 1 or 2 cardiologists or physicians managing heart failure alone. You have to have what we call force multipliers. You have to have physiotherapists, heart failure nurses, device programmers. So the various components of heart failure. You have to have a surgeon, dietitian, and these are all there in your hospital services. You just have to get them together at one point, and that's what creates a heart failure service, a heart failure clinic, and heart failure nurses. And this is definitely helpful. I don't need to go into the data. There's a lot of data that shows that creating a heart failure service, a heart failure clinic, along with heart failure nurses, is definitely beneficial in terms of reducing the morbidity, and there's some data that it can also reduce the mortality. And the essence is that it has to be a multidisciplinary approach. It can't be just one person creating this service. This is just some data. Could I request the mics to be switched off? I think there's some background noise which is coming. Now, this is just some data from our heart failure clinic. When the patients enter the clinic, about 80% of these patients are on vasodilators, but at low doses. 50% of these patients are on beta blockers. But by the time we have seen them for about a month or so, we try and ensure that almost all the patients are on some form of vasodilator to the maximum tolerated dose. All patients are on some form of beta blocker and or ivabradine. We try and attach the rest of the drugs like SGLT2 inhibitors. Now we're gradually gaining experience with Vericiguat. We try to ensure that the patients are given advice regarding vaccine. So initially it was influenza pneumococcal, now it's also COVID vaccination, because we still find that patients are still not fully vaccinated against COVID. Then we also ensure that all patients are not on a MR. This is what I call my ABCD approach. So A is your ACE inhibitor or other vasodilator. B is your beta blocker and ivabradine. D is your diuretic. C is everything else which is gradually coming up. And with this, the outcomes have definitely improved. Almost 50 plus 37% of patients are stable or they've improved over their initial status. But obviously, every patient can't be improved by just drug therapy. So we have about 13% of the patients who remain sick and are then eligible for advanced heart failure therapy, which include transplants and LV assist devices which are available. And you have to understand they are available not only in the government but also in the private sector. So wherever you stay, you will be easily able to find a service where these are available. With that background, now let's talk about supposing you do want to set up a heart failure clinic. How do you set it up from scratch? The various components of it. Now, for instance, as Dr. Pandey was telling, they have a OPD service every day. So obviously you don't have to start by saying that one day of this will be a heart failure service. You can just say that, okay, maybe once a week for 2 hours, you will start a heart failure service. It can be something like in the evening from 5 to 7 or 3 to 5. You say that one particular room will act as a heart failure service. So all three or any one of the doctors can stay in that heart failure service. During that time, gradually you bring in your sicker patients. Try to put at least 1 or 2 persons there who will act as counselors. They can be dietitians, physiotherapists, nurses. Even your OPD attendant can be trained to provide the initial counseling. So that way you can initiate your service. So now, which are the patients? You don't want to see all the heart failure patients in a heart failure service because that will dilute the effort. So you focus on the sicker patients. Patients who were recently hospitalized are prone to getting re-hospitalized. Other patients who are high risk, for instance, if they're renal insufficiency, diabetes, lung disease, who are staying in class 3 or 4 are getting repeated hospitalization. These are the patients where you need to give them extra time. So if you, for those 2 hours, just see these sick patients, it will be easier for you to focus all your energy on these patients. These patients will talk to each other, they'll give advice to each other, and they'll share experience with each other. So in a way, they're counseling each other also because they're sitting together waiting for their turn. That I find is very useful. What are the components of a heart failure clinic? You gradually build up all these components. You talk about disease management. The patients are taught how to look after themselves. So you and your counselors are teaching the patient self-care. They are taught how to up titrate, down titrate their diuretics. They gradually learn that some of these drugs can cause hypertension. So they should be able to avoid these drugs when they are very hypertensive and then restart them when they're better. So some amount of self-care and confidence in themselves is built in. You need to have some form of functional assessment. It can be just a simple thing like an NYHA class for each patient that you write down. During each visit, you ask the patient, are you same as before? Are you better, worse? Can you climb one flight of stairs? And is your shortness of breath worse or better on a scale of 1 to 5 or 1 to 10? So generally what we do is we'll write down the NYHA class. We'll ask each patient, can you go to the nearest bus stop? Can you climb one flight of stairs? Those who can't are obviously sick patients. You can, if you want, if you're not very clear about the symptoms still, teach 1 or 2 of your health workers to do a 6-minute walk test, which is very simple. You just find an empty corridor just behind your OPD where there's less of rush, mark off some points and do a 6-minute walk test. It's a fairly simple to do and very useful test that I find where I'm not very sure about the functional capacity of a patient. You can sometimes use some tools which are freely available, the quality of life tool like SF12, SF36, and they supplement your subjective assessment of the functional capacity of a patient. Drug therapy, you should try and ensure that each patient gets appropriate drug therapy as per guidelines, and if some drugs cannot be given, it gets written down that these drugs were not started right now, will be started later. We have certain tools that which we have developed. One is called the Hriday card, which is basically an education come checklist card. It's just a 4-page card in which we just write down the patient details, and it helps us educate the patient and also gives the patient something to carry. And we have various checklists that we have created, very simple checklists for the OPD and for the ward. We try and ensure we don't have a person who's coming to program in the OPD itself, but we try and ensure that all the patients are guided to where someone is available on whatever day available for programming devices. Here also, for instance, at AIMS, we have a pacemaker clinic on one particular day. So Wednesday morning is a pacemaker clinic. So all the companies representatives will come with the programmers, and for those 3-4 hours, any patient can come with their device and get it interrogated, reprogrammed under supervision of doctors. So that way you focus on one thing on a one particular day. Dietitians are also available. This way we are able to facilitate referrals to other hospitals and do other kinds of follow-up and rehab. Obviously, whoever you train for this has to be trained by you, or we do workshops for heart failure nurses. They can be part of these workshops and get trained on how to counsel patients. Record keeping is very simple. We have a Google sheet which I'll show you, in which you just put some basic details about the patient. So it doesn't require too much of information, just how to contact the patient, what the patient has, and later on, depending on what resources you have, you can build up this data sheet. And once in a while, you should do some kind of quality assessment and see that how many of patients are complying with the drug therapy, what is going wrong, how many are getting the various drugs that you have advised, how many of them require devices. So some kind of quality assessment is useful. This is now some of the tools that we use. So first of all, of course, you have to stay updated with the guidelines, and guidelines are coming out every year, and they're pretty simple to read. So guidelines for acute heart failure, chronic heart failure. Then you have to have some kind of training resource for your heart failure, the nurses or other paramedics that you've selected. And I'll just show some of this material. Guidelines, of course, are available on the net. We had set up some guidelines for India, which were simplified guidelines from the ESC and the American guidelines in a more practical and pragmatic way. So we had removed some of the things which are so absolute in the Western guidelines. But drugs keep coming up every year, and you have to keep updated with the guidelines. You have to have some kind of assessment of your in-house patients and outpatients. So in-house patients at discharge, some kind of a small little checklist which is there with the nurse who's discharging. Is a patient of heart failure? Has he had a LV function assessment? Is the patient on beta blockers, ACE inhibitors? Has the patient taken a post-discharge appointment? So whatever is missing can be quickly corrected. Same with the outpatient, similar kind of simple checklist should be there. So now we have checklists for various aspects. So let's just go through some of them. This is our heart failure admission checklist. So this is used by the residents, starting from diuretics, how and when to use, IV inotropes, when to use and not to use, ACE inhibitors, beta blockers. How do you start a beta blocker? You don't just start beta blockers for fast heart. You start when the patient is stable. So it's just a simple, this is just half a page, the rest of it. Then is the patient being treated for other things? You have given heparin for a bedridden patient, anticoagulants for patients who have clots, or if coronary artery disease is there, have you started statins, seen a lipid profile, aspirin is there. Same for vaccination, diabetes. And finally, at the point of discharge, has the patient been given an appointment for within a week of the discharge? Now, we have found that implementing this kind of checklist does reduce the hospitalization and does improve the outcomes of these patients. Now, OPD, this is just a glimpse of a part of the SF36. We use just the physical score component. So it's very simple. That are you limited a lot, limited little, or not limited at all for various levels of activities, vigorous activities, moderate activities, lifting weights, climbing flights of stairs, walking more than a kilometer. So simple things. If you just score these from 1 to 3, then the best patient has a score of 30. There are just 10 questions, and gradually you can score each patient this way. This is the most important checklist that we use. This is the OPD checklist. So we write down the contact details of the patient, we write down the disease of the patient, and how is the patient? Is the same, better, or worse than last time? What is the NYHA class? And can the patient climb one flight of stairs? And then the checklist of A, B, C, and D. And this page is then retained by us. And the next day, one of our data entry operators will enter some of this data or in a simple Word file. So they have a small little box per patient, and it will be entered in a version, also in a Google Sheet. So that is the level and amount of data that we retain. And this is what we have on our OPD card. We have a stamp by which we write down A, B, C, and D for these patients. Just a glimpse of one of our prescriptions. So you ensure that you write the drug in the correct category, and ensure that suppose you missed a drug, you can remember to add that drug. And for some of our resistant patients, sometimes what we do is we even give them Ziplocs with A, B, C, and D written, and we tell them that remember to take your drugs from A, B, C, and D, and bring these drugs when you come to us, so that we know that are they refilling their prescriptions or not. This is a glimpse of a Hede card. It's a thin cardboard card, and inside that there is a medicine checklist, a daily weight monitoring chart. Behind that, so this behind that is an educational pictogram by which you can give advice to the patient. You have the front detail, and this can be actually used by any hospital. So it's not got aims written. Not any hospital can just acquire these cards from us, and they can then print their hospital name or put a hospital stamp here. This is a glimpse of the medicine charts and weight monitoring charts. And we also teach the patient about how to respond in a emergency situation. There are some various kinds of education booklets which you can create in your local languages, or adapt some of the booklets which are available with various pharmaceuticals. Now, we have developed an app also with IIT Roorkee. This is called the Dharkan app. It's available in Google Play Store. It's a very simple app. Once the patient and you have registered yourself on the app, then the patient just has to once a week or once a month, as you designate, enter the body weight, heart rate, blood pressure, and that's all. And once they present save, the data comes to you or your heart failure nurse, whoever you assign this app. And with that, you keep getting information once a week or once a month, and the nurse can be then trained to pick up any anomalies. For instance, the weight has increased suddenly, or the heart rate has increased, or the blood pressure has fallen. They can respond to that. You do need to understand that this is not an auto response app, so it's not a substitute for a doctor. It's just providing information about the patient once a week, and it's creating a trend where variations can be picked up, and the patient can be then warned in advance. Prognostication, it's good to have some way to prognosticate the patient so that you know how sick a patient has. There are various kinds of objective algorithms available. This is a very old one called the Seattle Heart Failure Calculator, and this can be used. Some of the newer ones are like Magic. A recent one which is very useful is the Barcelona Heart Failure Calculator, because this is the only one which has BNP biomarkers in it. The previous ones did not have biomarkers in it. We're also trying to create a simple calculation method, because it's sometimes in a busy OPD not possible to open an app, enter parameters, and then wait for an answer to come. So we're just trying to validate a simple thing like this, that you give 5 points each for a high BNP, hospitalization within 3 months, and similar parameter, and if the score is very high, that's a poor prognostic marker. Another algorithm is what is called the I need help. So patients who are recurring repeated inotropes, persistent high BNP, organ dysfunction which is not improving, low ejection fraction, defibrillator shocks, multiple hospitalizations. These are sick patients where you have to focus your energy, and sometimes many of these patients are actually not going to respond to drug therapy, and you might need some advanced therapy like a transplant or assist device. So with that background, and you've seen the tools, now how do you initiate your clinic if you want to start? You can start with a simple thing that you designate 1 or 2 hours of the week as your heart failure service, and get anyone to help you. It can be a student, it can be a nurse, PhD, it can even be an attendant, or even a patient who's recovered who says, I want to do some extra work with you. So find some help and start training that help gradually. You can train them on how to do initial counseling regarding diet. That's very simple. And gradually let them start collecting some information, like filling part of that checklist, and then gradually build up that. Once you find that this is useful, you'll gradually find that your hospital or the people will be more than willing to help you. You can use a checklist card like the Hriday card for education, medication adherence, data collection. Then you create a helpline. The helpline is very simple. You just use any prepaid number, tell the patient this is available 5 days a week in the morning hours, and if you don't find anyone picking up the phone, send a WhatsApp message and someone will phone back. And this phone can stay with your assistant or your receptionist or even one of your residents, someone. So the patient knows that they will not always get someone picking up the phone, but they can send a WhatsApp, and you try and ensure that daily at least someone checks these phones in the morning hours and preferably respond to the phone call at the same time. So again, this is not very costly, just any old phone will do, and just annual payment for a prepaid number. This is our heart failure clinic. We have it on Thursday afternoons, runs from 2 to 5 or sometimes 2 to 6 or 7 depending on what kind of load we have. Many of these are referred patients from outside, but even there are in-house referrals, especially with patients with end-stage heart failure who need to be considered for LVAD or a transplant, various kinds of unexplained heart failure, cardiomyopathies. Patients who had heart failure after surgery are more and more being referred to the clinic. There's just a glimpse, patients being seen by our counselors, by our research fellows, nurses. On the right lower panel, they're having a physiotherapy session in a yoga center. So various kinds of activities which ensure the patients feel better. We have a cadre of heart failure nurses, so we usually have about 3 nurses at any time who are gradually trained to be able to handle this. Is one of our transplant patients being seen post-transplant. So they are able to take samples, fill the checklists for the transplant patients, and even do echocardiography. So it becomes very easy for us to see these patients that way. We have created a separate heart failure manual for training the nurses. So this is available online. You can get access to this easily. And you can use this as an initial start for training your paramedics and nurses. This is the prepaid number that we have. We tell the patients only available in the morning hours. Usually someone will pick up the phones. Even if they don't pick up, you send a message, someone will respond to that. This is a glimpse of the Google Sheet, very simple Google Sheet. So it contains the patient details, name and contact details, and the diagnosis. It contains the first prescription and the last prescription. It doesn't contain anything extra. So it's very simple to maintain. Rehabilitation, we have the nurses have also been trained. This is one of our nurses showing the patient how to do rehabilitation, and it's simple set of exercises in which most of the exercises are conducted sitting or lying in the bed. So there is no risk of the patient getting hurt by falling by doing vigorous exercises. This is one of our yoga instructors teaching the patients how to do yoga, and these are all simple yogic exercises which we have shown very clearly that they're very safe in heart failure patients. These are some of our in-house checklists. I won't go into the details, but for various aspects like heart transplants, assist device, we have checklists for all that. And this is just a glimpse of our heart failure team. So a heart failure team involves basically the patients, the collaborators, the surgeons, the anesthetists, the dietitians. So it's actually a very big team because we make everyone realize that they're part of the team. And if a patient gets better, they're all responsible for improving the patient. That way everyone feels a part of one big family. Now, quite a bit of what I've talked about is available on this website. And if you have any queries, you can always send an email to me. And the heart failure education booklets for the nurses, some of the photos of the Hriday card, all these are available on this website. You can also scan this QR code. And I'll be very happy to take questions, and I would like to interact with some of you who would like to set up heart failure services in your hospitals. And that I think will be the essential program for the next 15 minutes.
Sir, good evening. I am Dr. Gururaj from Hyderabad,
Yeah.
consultant practicing in Hyderabad.
Okay.
Since almost more than a year, I am very much keen to start this kind of setup. But however, because of the resources available and the supporting staff in insufficiency, I am unable to go through it further. Definitely, I'm interested to go ahead the setting up. At the same time, where I practice, there is no proper transplant team and all. Start a heart failure thing. Now, how about if a center doesn't have a proper heart transplant and heart transplant and all? Do you still feel that this would work?
Yes, definitely. So if you can just give me an idea what kind of clinic and cath lab and OPD services do you run? How are your 7 days run?
Yeah, my regular schedule will be like any other cardiologist, like say morning hours and evening. I have my own practice in the clinic. Morning hours, I go to a hospital in a good corporate hospital. It's well equipped with cath lab and every other thing, city surgery team. Everything is there, except the heart transplantation, which occur in another branch of the same hospital.
Yeah, so fine. See, you are running, you're going to the cath labs and other things in the morning, but you have a OPD every day in the evening. So the first step you can do is, supposing your OPD starts at maybe 4 o'clock till 8 o'clock, you can say that on maybe Friday, my 6 to 8 time on Fridays will be my heart failure service. So at that time, you will not refuse any patient who comes who doesn't have heart failure, but you will start gradually focusing and calling your sicker heart failure patients on Friday 6 to 8 p.m. That time you can decide. During that time, then you train one of your assistants to act as a counselor. So while their patients are waiting to be seen by you, that assistant will fill that small little checklist that I showed you. He'll discuss each of those drugs with the patient, that look, this drug is essential because it will increase your urine output. Supposing you're feeling sick, you take more of this drug. Supposing you're feeling hypotensive, these are the two drugs, the vasodilators and the beta blockers, which can sometimes be problematic. So till you talk to your doctor, you can for some time avoid the next one dose, take a bit of sips of water and you'll feel better. Take less of salt, take less of water, get vaccinated. So he'll have a checklist based on something like this. They can't, he'll be talking to the patient while their turn is coming. So you can just start that those 2 hours. Gradually I'll focus more of my sick patients together, and the patients will also start talking to each other while they wait. For instance, you have 5 patients, they're all having an ejection fraction of 20%. One person says, I climb 5 flights every day. The other people will also feel, okay, look, looking at the ejection fraction repeatedly doesn't matter. That fellow can do 5 flights, even I can probably do it. So they'll start getting hope, which the other patient will give hope. So that's interactive thing which happens outside your OPD, and it's not something for which you have to do anything. So that's one way to start. And Hyderabad, for instance, has centers where transplants are going on, very good centers. So heart and lung transplants. So you just get in touch with the cardiologist or the surgeon there, that look, I've started a heart failure service. So if at any point I need to have a patient being considered for a transplant, I'll send the patient to you. For instance, Hyderabad has Dr. Gokhale, has Dr. Sandeep. They're all doing heart failure and transplant and heart and lung transplant. So you can stay in touch with them and through their cardiologist, and so that becomes the extension of your work. They will know that you'll be sending the patients to them, and you can tell them that, look, after the transplant is over, I would like to stay in touch with the patient. That way you will gain experience of how to handle a LV assist device patient, a transplant patient, after the transplant is done. So that is one way in which you can build up your service. You don't have to have a transplant and assist device program in your own hospital. And you said that it's available in some of the branches of the hospital in which you work. So that's quite okay with that. The
Yeah.
initial thing can be done there only, and gradually, when you're confident that you have a big turnover and your surgeon is also interested in working on this area, he can pick up extra training and then start doing transplant if you feel. But that is not absolutely necessary for starting a heart failure service. You don't
Okay.
have to start creating that additional service.
Okay, sir. Sure. Thank you very much.
Welcome. Anyone else would like to ask anything? So I think if there are no other questions, then I've given my email. Anyone else who thinks of any question or would like to interact can interact with me directly or through JB Pharma. And gradually we can help each other in creating heart failure services. This is from Dr. Ravi. What is the importance of a one point of contact in heart failure clinic? So what we have is that we have at any time we have 3 heart failure nurses. Plus we have this helpline number. See, I generally don't give my phone number to any patient because initially I used to give it, but then I would get phone calls at any time of day and it was very difficult to handle those phone calls. So currently I don't give any number and I tell them I'm not available 24 hours a day. It's just not possible for any doctor, neither myself nor for any of you to be available 24 hours, especially for a heart failure patient who's sick. So what I tell the patient is that you, in case of an emergency and not able to contact any of us, go to the emergency service. We have a cardiology resident on call round the clock. So they will see you and they will contact us if they can't handle it. But otherwise, at least 5 or 6 days a week, in the morning hours, definitely, while the nurses are on duty. The nurses are on duty from 7:30 in the morning till about 5 p.m. Daily, except Saturdays are half day, Sundays off, unless we have an admitted patient with a transplant or assist device, then they will be available at that time. And so during that time, this phone runs. It's a prepaid number. It's a Airtel prepaid number, so doesn't require any extra resources. Once anytime any patient makes a phone call on this, we write down the patient's, store the patient's name on that phone. We ask them to WhatsApp their OPD card on. So this phone is also the WhatsApp is acting as a sort of storage for that patient. Next time he makes a phone call, we can quickly open the WhatsApp of that patient and see what disease he has, what was his last set of investigation. So that phone becomes your database. It's your helpline, and that becomes your sort of one point of contact. We also have an email which we give them sometimes. So email is easier to handle because it doesn't require emergency response. So there is some way by which all the patients can contact us, and that is the way we do it. Another question which has just come up about heart failure nurses training. So I have been running these training sessions. We did one about a month ago. So they are training sessions for heart failure counselors. They're training sessions for heart failure nurses. So depending on when there is need, I do it through the Heart Failure Association of India, but also sometimes through as simple workshops that I arrange from AIMS itself. So initially before COVID, there used to be physical training sessions in Delhi, but because of COVID, we've learned to go online. So these sessions are available. So whenever there's a need, whenever there are at least 15, 20 centers or nurses who want training, these are simple focused training sessions which I conduct along with my nurses. So I'll give an introduction. Then my nurses will actually conduct. So they are well trained to conduct the training programs also. So that's how we do these training sessions. And they can be repeated as and when required.
So apart from the HFAI, is there any other internationally acclaimed, certification kind of a thing that can be done?
No, initially there were attempts by various pharmaceuticals to try and get the certification programs from outside, but then at least I realized that we don't really need a certification program from outside because our training has to be India based. So we don't need people from outside coming and certifying us. So most of our sessions are like this session that we talk for about half an hour, 45 minutes, and then we interact with the nurses. And after maybe 2-3 months, we supplement it by another training session. So it can be for simple heart failure clinics, it can be for a transplant, a LVAT. So depending on what kind of nurses want to be trained or counselors want to be trained, it's focused like that.
So it is a question which says that is there any sessions can be taken for patients on living with heart failure, guiding them through their disease, maybe counseling them?
Yeah, so we can do it as an interactive session. For instance, we can have a session where the doctors who are treating the patients are there and some of the patients come online also. And then we can talk for the lay persons for 5 minutes. Like this, the kind of public health talks that we give from AIMS, that we have it in our auditorium. So this can also be done online, that every of the participating doctors who want some of the patients to interact, they can all be brought online, and then we can give an outline of heart failure for the layperson, and then the patients can start asking questions. That is very easy to organize, should not be difficult at all.
Right, so I think social media can be very beautifully leveraged for this because,
Yeah.
yeah,
So some of the patients who are on Facebook, Twitter, all those things can happen. Otherwise, just a simple online session.
right, understood. Sir. Sir, another question from Dr. Gururaj Kulkarni, whether HFAI is actively taking memberships and how to approach them.
You type on the net Heart Failure Association of India and go to the website. And on the website, then there are instructions to how
Yeah.
to become member. That's very easy.
So another question is, sir, that we have these digital risk calculators, quality of life calculator like the Cancer City questionnaire, or Magic or the program. So are they really helpful? I mean, if they are like kind of put it into a handheld device, and the patients have to enter their symptoms, and then that
See, there
calculates the
there
risk.
are two things. So you have a device. You have online calculators. So KCCQ is now a paid questionnaire. So they charge heavily for it, but you don't really need it. For simple calculations on prognosticating your patient, you can use something like the Magic or the Barcelona heart failure scoreboard. That's available online. It's on the net, so you can just switch it on your phone and do it. And for the sicker patients, if you want to just say this patient is sick or not sick, use the I need help. So just follow that algorithm that I is needing inotropes, N is your natriuretic peptides are high, so E is edema is there. Then similarly, patient is not tolerating beta blockers or ACE inhibitors. So you separate out that 5% of patients who are very sick, and for the rest of the 95 who are not so sick, you can use any questionnaire which you're comfortable. The Seattle is a very old questionnaire, doesn't contain biomarkers. Barcelona contains the biomarkers, so you can fill in the information for that, and the calculations can be done online later when the clinic is over. And you can just write down the risk, like you write a risk for CAD, like using the Q risk 3 or something. You can use the Barcelona questionnaire and create a risk assessment for each patient that's available in that patient's records.
And finally, sir, coming to the caregivers of heart failure patients, how?
Yeah, see, all of us are also caregivers for these patients. So if you think of it like that, plus the relatives of the patients, we have to, the most important thing I found for the heart failure clinic is that we have to learn to listen to the patient. So if you just spend 2 minutes quietly listening and asking the patient, what have you come here for today? He'll say, I can't eat anything, I have indigestion. And you know that indigestion can be from anything like digoxin toxicity or just congestive hepatomegaly. So you have to first listen to the patient and try to alleviate the patient's symptoms. The caregivers also have to be counseled that look, heart failure is not the end of the road. So don't think that your patient is going to die. Think that you will make the patient as comfortable as possible. And some of these patients are actually going to do pretty well for the next 5 to 10 years before they start either worsening. And many of these patients actually will have reversible cardiomyopathies, myocarditis, which recovers something. So you don't have to think that patients cannot be treated. Many of these patients will actually improve dramatically with proper medication. So they have to be given hope. I think that's the most important thing, that patient and the caregivers have to be given hope that look, things can be done. If ultimately, and if everything else fails, you also have a transplant or assistive. So there is therapy for each aspect of heart failure. That has to be conveyed.
So, and one last question from my side. So, as a pharma organization, if we are attempting to spearhead this initiative of establishing heart failure clinics across the country, and especially in the rural areas, what are the challenges that we should be wary of, that we should foresee in this
See,
area?
you have a very big field force.
Right.
Most of your people are from the B pharma background, majority of them. So they already are 5 steps ahead. They already know the pharmacology, they know the drugs. So they are the first people whom you should train. In fact, when I started my heart failure clinic, I had basically just 2 rooms, which was a legacy from our heart transplant programs. I was just given those 2 rooms, and I had nothing else. I didn't have any counselors, anything. So the first person who volunteered was actually someone from one of the pharmaceutical companies. And this is an example I give everywhere. He said, I'll help you with your counseling, and I'll help create a database. So he is the first person. So for 2 hours, he would sit every week, forget that he's from a pharmaceutical company. He would just interact with the patient, give them counseling as per the instructions I had given him, and note down their basic details on a very simple checklist, and then go home in the next 2 3 days, enter the data on a Google sheet. So he was my first counselor, and when I started showing that these are useful, and the heart failure clinic data started showing that the patients are getting better and better, then I asked the hospital, look, can you give me a heart failure nurse? Give me a nurse and I'll train the nurse. At that point, but by that time, our transplant program had also picked up dramatically. The numbers were increasing. The surgeons were also finding it difficult to handle these patients alone. So ultimately, the center gave me 3 nurses, not one. I had asked for one only. They said, you can't manage with one, you take 3. So first, you start with zero resources. Try and get anyone to help you. Now it can be some, since you are offering help, it can be someone from JB Pharma or someone. For that 2 hours, he will forget that he's from a particular company. He'll just help that particular doctor. And I think you will have more than 100, 200 field operatives.
Yes,
So you
more
can
than that.
practically cover all of India, whether it's urban or rural. You can cover just about every aspect of part of India.